So today I'll be talking about this topic, fungal infections in ICU. So this talk I gave in Baptist Hospital on 28th August 2019 in their internal medicine CME. So the topics I'll be covering is background, and when you talk about fungal infections in ICU, predominantly 80 to 90% of them are Candidemia. So pretty much I'll be covering about Candidemia in this talk because only 10 to 20% are constituted by molds like aspergillus is one of the commonest cause. So Candidemia, the topics I'll be covering is epidemiology, modes of spread, and EPIC 2 study. A bit about non-albicans. We'll talk about Indian data, and we'll talk about risk factors for Candida albicans and Candida non-albicans. We'll talk very briefly about antifungal agents because this is extremely important for all the trainees. We'll talk about azoles, polyenes, echinocandins, approach to antifungal treatment, and take-home message. So when we talk about Candida infections, these infections can occur in immunocompetent and in immunosuppressed patients. So the epidemiology and risk factors for these can be quite variable and may be different between immunocompetent and immune suppressed. And as I said, invasive pulmonary aspergillosis constitutes around 10 to 20%. And predominantly, this pulmonary aspergillosis occurs in solid organ transplant patients. So, since my topic is in immunocompetent, so we'll talk more about Candida infections, albicans, and non albicans. So as you see, this is a study from the Switzerland, where they have shown that Candidemia accounts for predominant fungal infections in ICU, up to 90%. Only 10 to 20% is caused by invasive mycosis, and even these mycosis predominantly occur in solid organ transplant. So what is Candidemia? Presence of Candida species in blood, like any other septicemia, is called Candidemia. And is Candidemia important for us to know? Yes, because the mortality is pretty high. So these are two studies from US where they have shown mortality up to 57% in one study and 34%. But I have to say in India, the mortality, at least from some of the studies which has come from some of the hospitals, has shown much higher mortality, up to 70%. So in the most Western studies, the mortality falls around 40 to 45%. So, and if you do not treat this candidemia, so the mortality can be much higher. So, this was one study where they showed in 28% who were not treated, 63% died. So, the mortality can be up to 70% in someone who is not treated. And another important thing for us to remember is it constitutes 5 to 15% of healthcare associated infections, which means it is one of the fourth commonest cause of nosocomial infections. So, as I've already mentioned, so it does come within the five common causes, and it's the fourth commonest nosocomial infections. So this is a one of the big study which came in JAMA by Jean Louis Vincent, where they looked at the prevalence rate of candidemia across all the countries and across all the continents. As you see, they had Western Europe, Eastern Europe, Central America, North America, Oceania, Africa, and Asia. So what they found is the candidemia prevalence rate somewhere was between 16 to 17%. As you see, most of these continents, you would see the prevalence rate falling between 15 to around 17 to 18%. And aspergillus, you see it is around 1.4 to 1%. And here, as you see in this big study which came across the continent, 62% of the commonest infections were gram negative, followed by gram positive, and 19% were fungi. So they took the median as 19% as fungi prevalence across the globe. So this was again another study which looked into the mortality correlation. As you see, this was a study from USA, and even here you see Candida species accounting for fourth commonest cause, around 7.6%, and the crude mortality was 40% in this study. So what is the modes of spread? I think the modes of spread of Candidemia predominantly happens with gut translocation, because gut is full of fungi. So when there is a breach of gut mucosal barrier in in a very sick patient, or where the mucosal integrity may be breached due to various other reasons, so Candidemia can occur. I think that is one of the commonest cause of spread of Candidemia. So which means any sort of a individual who is quite deconditioned or who is recuperating from a infection where the gut mucosal integrity is lost, so there is an endogenous spread of Candida from the gut, which is the commonest cause of infection. The second most commonest is the hands of the healthcare professionals. So like any other infection, hands are the commonest mode of spread of infection, or fomites. So any of the contaminated objects in ICU, or any of the instruments, any of the equipments that patient may be connected to, if it is they could be contaminated with Candida, and that can cause nosocomial infections. And the commonest sites of Candidemia most often has been found to be the surgical wounds, because any of the surgical wounds, and primarily the abdominal surgical wounds, become the harboring sites of Candida. And urine also is one of the commonest cause of getting colonized with Candida, and from here they have bloodstream translocation and then lead to Candidemia. So that is how the Candida albicans look on a smear. So this is a very important study which I think most trainees should be aware of, EPIC-2 study. So this study was done in 1265 ICUs across 76 countries to look at the prevalence of Candida bloodstream infection. So this is one of the landmark studies. So they included 14,414 patients who had bloodstream infections, out of which they saw that 99 patients had Candidemia. So this is the largest global study, out of which 69 patients had only Candidemia and 38 patients had combined Candida and other infections. And the prevalence rate was 6.9 per thousand patients. So for all the trainees, if you would want to know the global prevalence of Candidemia, bloodstream Candida, it is around 6.9 per thousand patients. And this study also looked into the mortality. I think for all the trainees, if you want to quote the mortality associated with Candidemia, as you see, the ICU mortality here was 42.6%. As you see, it's 42. Hospital mortality is also around 42.6. And if you look at the ICU length of stay, what is striking is people with Candidemia will stay longer in ICU. They stayed for the median duration of 33 days. As you see, the longer they stay, the higher is the risk of Candidemia, or vice versa. Candidemia tends to stay longer in ICU. So let's look into a bit of non-albicans. So non-albican species also are problematic. The commonest ones are Tropicalis, Parapsilosis, Glabrata and Cruzi. In India, predominantly non-albicans that is prevalent is Candida tropicalis. And what all of us should be aware is these are dreaded species. Candida glabrata and Candida cruzi occur in more immunocompromised patients, and they are dreadful as they are resistant to fluconazole. So if you are dealing with a immunocompromised where you believe there is a Candida glabrata that has been isolated, then fluconazole is not the drug of choice. That is something all of us should be aware of. So this was another study from USA done in 16 hospitals, where they showed 43% were non-albicans. So predominantly it is Candida albicans, but what we need to also remember is significant proportion of them can be non-albicans. In India, so I want everyone to remember that it is predominantly non-albicans, and Candida albicans occurs second. So I'll show some of the data. And in this US study, Candida glabrata caused 25% of Candidemia in elderly. So in elderly patients after 65, I think 25% of them had Candida glabrata, which is resistant to fluconazole. So that is what we need to keep in mind, that if you are dealing with glabrata or cruzi, fluconazole may not be the drug of choice. So what we have seen is from 1980s, predominantly it was Candida albicans and 24% was non-albicans. So as with the passing decades, we have seen the transition of albicans to non-albicans. As you see, in 2000s, it is non-albican, the occurrence rate or the proportion is significantly increased. It's almost doubled. So what we need to understand is globally there is a shift from albicans to more occurrence of non-albicans. And in these non-albicans, these were the commonest ones found in US data. Glabrata 16%, Parapsilosis 15%, Tropicalis 10, Cruzi 2 and others 3. So again I have to reiterate, in India Tropicalis is the commonest occurring Candidemia in ICUs, ahead of albicans also. So what are the important fungal pathogens based on medical literature that are found in India? In India, albicans is found, like as I've been reiterating and re-emphasizing, amongst non-albicans, all these are seen, but most commonest is Tropicalis that is seen. Amongst Aspergillus, you have all these species: Aspergillus flavus, Fumigatus, Tereus, Niger. and nidulans. I think in India we commonly see fumigatus and Aspergillus niger. I think what I need to sensitize the listeners is to this dreaded species called Candida auris. I think there is a re-emergence or occurrence of this Candida auris, which is most devastating fungi because this is resistant to fluconazole and even to echinocandins. So I think the only drug that may be more effective is so we have to use combination of the drugs. So I think these are becoming inherently resistant to the azoles and echinocandins. I think that is something we need to keep in mind. So what about the Indian data? So if you look at the Indian data, Candida tropicalis appears to be the commonest. As you see, the 38 percent had Candida tropicalis, followed by Candida albicans, followed by Guillermondi. So in India, the data is quite different to the Western data. So tropicalis remains the commonest, followed by albicans and Guillermondi. But as I said, Candida auris is also becoming a problem. So for Candida auris, I think the drug which is currently being used is IV posaconazole because before it was only available as oral. So now it is available as IV. It is found to be effective. So auris is something I want everyone to keep an eye on because that is more devastating if it happens in any patient. So when you look at this Indian data, this Gangaram Hospital, Safdarjung, STPJ and AIMS, so Candidemia, the occurrence rate was around 27% albicans. When you look at non-albicans, you see predominantly it is much higher. 88.5% of this Candidemia had non-albicans. In AIMS, it was 79%. And Tropicalis, as I said, was the commonest, followed by Glaberata. And mortality, as I said, in Indian data, if you look at the EPIC study, the mortality was around 42%. But if you look at the Indian data, mortality is much higher, 55. In AIMS study, it was 72.2%. And they have in fact shown resistance to even amphotericin in All India Institute of Medical Sciences. So this is our sort of rough Indian data that we have. So Candidemia, the occurrence rate in ICU is around 27%, and predominantly you see more non-albicans in India. So now we have finished about the occurrence rate or the prevalence of Candida and what are the statistics that are prevailing in India about non-albicans. So how do we go about suspecting the patients who may have Candida? We have something called Candida colonization index. So you calculate with colonization index as number of colonized non-blood sites divided by total number of body sites cultured, and CCI is Candida colonization index. So you calculate by colonization index into number of sites with heavy growth of Candida divided by total number of positives. So basically this will help in identifying patients who are at a higher risk of developing Candidemia based on ascertaining the colonizers that may be present. So why is it important? Because they have found that colonization has a significant pathophysiological correlation with the occurrence of Candidemia or active Candida infection identified by pulse field gel electrophoresis. So you have higher colonization index, the risk of them having Candidemia is much higher. So you may have in the case of high index of suspicion, you may have to start therapy where your colonization index may be higher. So I think there is something called Candida score, which one could also apply to determine which are the patients who are at a higher risk of Candida infection. And in a given clinical context where you suspect there is a risk of Candidemia, you could consider starting empirical antifungal therapy pending cultures. So Candida score is you give one for TPN, one for surgery patients, one for multifocal colonization, and two for clinical severe sepsis. So the cutoff value is 2.5. So basically you give one score for TPN, one for colonization, one for undergoing surgery, and two for someone with severe sepsis. If your score is more than 2.5, so then the sensitivity of them possibly having Candida is around 81%, specificity is around 74%. I think this is a easier tool that one could apply. So someone on TPN, someone with a Candida colonization who has undergone surgery, and two for severe sepsis, more than 2.5, you know they are at a much higher risk of having Candidemia, and you could consider when other tests are coming negative in these patients. So the risk factors for Candidemia I put in a pictorial format so that all trainees can remember. There are around 11 risk factors. So the highest risk factor is for someone who has CVC. So as you see, the odds ratio was 9.5. So if someone has a CVC, the risk of them developing Candidemia, odds of them developing is around 9.5. That's the highest risk. Followed by stress ulcer prophylaxis, you have an odds ratio of 6.4, and just the fact that patient remains in ICU for longer time is one of the risk factor for ICU. Or someone who has high Apache score or who is very sick, he is at a risk of developing Candidemia. Or someone who is on a Riles tube itself can increase the odds of them developing Candidemia, the odds ratio of 3.7. Or inappropriate antibiotic usage increases the risk of Candidemia. Or someone who has a bacteremia, someone who has had abdominal surgery. As I said, abdomen is a good sort of a culture media for fungal infections. Anyone who has undergone abdominal surgery, laparotomy are at a risk of developing Candidemia. Or someone with renal failure is at a higher risk of developing Candidemia or any anastomotic leak. So for all the trainees, the key thing to remember is someone with a CVC, someone who is having stress ulcer prophylaxis, and someone who is in ICU for a longer time or inappropriate antibiotic use. I think these remain the top five culprits for someone at a risk of developing Candidemia. So that's why our sensitization must be to reduce our antibiotic usage and more so mitigate the usage of stress ulcer prophylaxis. So, what are the risk factors for non-albicans? So, non-albicans, the main risk factor is someone who's had a fluconazole exposure. So, that's why we need to temper down or reduce the usage of fluconazole, because if someone is exposed to fluconazole, the risk of them developing non-albicans infection is very high. The odds is 11.6. So, very high possibility of them developing non-albicans. And someone again who is on a CVC catheter, the risk for non-albicans almost doubles, and someone who's had a laparotomy. So the main risk factors the trainee should remember is mainly CVC, stress ulcer prophylaxis, inappropriate antibiotic usage, or someone who's had a abdominal surgery or who's on a laparotomy, and longer stay in ICU. I think these remain the sort of a main risk factors one should keep in mind. So this is another study from Australian prospective cohort study for 3 years. They have looked at 179 Candidemia. As you see in the Western setting, albicans remains commonest. In Australia, the second commonest was glabrata, followed by cruzi, and others constituted 16. But as I had again re-emphasized, in India it is always Candida tropicalis, which is commonest. So let's look at the antifungal agents. So we have three groups of antifungal agents: azoles, polyenes, and echinocandins. Azoles, fluconazole is what we commonly use. So the dosage is 12 mg per kg per day, which is 800 mg per day on day 1, followed by 400 mg per day, 6 mg per kg. And voriconazole is claimed to be superior to fluconazole, and the main reason voriconazole one could consider is if you are having a suspicion of someone having cruzi or glabrata, then obviously we know fluconazole may not be effective, so voriconazole may have to be considered, and it is shown to have low MICs for voriconazole. So as I said, posaconazole is mainly was available only as oral, and it was being used as prophylaxis for graft versus host disease, stem cell transplant, and hematological malignancy. But now posaconazole IV is come, and for Candida auris, which is inherently resistant to fluconazole, posaconazole is something that is being tried. So for polyenes, amphotericin B is the commonest and drug that has been available for more than 2 decades. The dosage is 0.5 to 1 mg per kg per day, but we need to keep in mind that it has no effect on Candida lucitanae. So liposomal amphotericin B, because we know amphotericin B is nephrotoxic, so liposomal amphotericin B is less nephrotoxic, so the dosage is 3 to 5 mg per kg. So there are other agents like amphotericin B lipid complex or amphotericin B colloidal dispersion that are available that may be more expensive. Echinocandins, the commonest ones, the first one which came was caspofungin. We give 70 mg as a bolus, followed by 50 mg once a day. Anidulafungin we use as 200 mg bolus, followed by 100 mg once daily. Micafungin we use as 150 mg, followed by 100 mg once a day. So these are some of the echinocandins. In liver transplant patients, there is a preference to use anidulafungin as it is found to be less hepatotoxic, and caspofungin is being shown to have little effect on liver enzymes worsening. So that is something for someone dealing with liver dysfunction to keep in mind. So how does these antifungal agents work? So when you look at the structure of the fungal cell wall, so it has a fungal cell wall here, and this cell wall is made up by these beta 1,3 glucans, and then you have this cell membrane which is made up of phospholipid bilayer, and then you have this molecule, this protein called beta 1 glucan synthase, which helps in the synthesis of beta 1,3 glucan. So when you look at the azoles, so basically all the azoles, fluconazole, they act by inhibiting the synthesis of this ergosterol. See this yellow thing, what you see is ergosterol, which is needed for the synthesis of cell membrane. So this azoles helps to it inhibits the production of ergosterol, which is needed for the production of this cell membrane. And polyenes, so basically by inhibiting the synthesis of ergosterol, your fungal cell membrane is disrupted, and then fungal lysis or killing of fungus happens. Polyenes like amphotericin B, this violet one what you see is the sterols, which maintain the integrity of fungal cell membrane. So polyenes bind to sterols and then causes disruption of cell membrane. And all the echinocandins, as I said, this big protein what you see is beta 1,3 glucan synthase, which helps in the synthesis of this beta 1,3 glucan, which maintains the cell wall integrity. Echinocandins inhibit this beta 1,3 glucan synthase. So what it leads to is the breakage of this cell wall or inhibition of the synthesis of beta 1,3 glucan. So that is the mechanism of action. So if you want to look at the sites of action, so as you see, polyenes, which amphotericin B acts on the cell membrane. Echinocandins, it inhibits the production of cell wall, so it acts on the cell wall. So azoles, they inhibit the sterol synthesis, so act at the cytoplasm. And DNA 5-fluorocytosine acts on the DNA of the nucleus. So these are the sites of action of these antifungal agents. So when we look at the treatment of fungal or candidemia, there are four aspects of treatment. So one is prophylactic, the second is empirical, third is preemptive, and fourth is targeted therapy. So which means when we talk about therapy, these are all, there is sort of a complex interplay between what we are using. So we have to be very clear. So when there is absolutely no disease, then you are using antifungal agents, then it is called prophylaxis, and this you use in a high risk patients where you assume that they are at a much higher risk of developing fungal systemic fungal infection or candidemia. And these high risk patients may be someone who's had a bone marrow transplant or who's had a solid organ transplant. And preemptive is where you have these markers that has come positive. When I say markers, you can look at Candida colonization index or Candida score. And where Candida colonization index is high or your Candida score is high, but patient is asymptomatic, and you sort of make an assumption that they are at a much higher risk of developing candidemia. That's why you start treating them. That is preemptive. Empirical is where patient has signs and symptoms. He has fever, where all your other cultures are coming negative, and then you know that Candida score is high, and where he is already on antibiotics. So you will start empirically considering that he may have candidemia. The fourth one is targeted therapy. Targeted is where your culture has yielded Candida in the blood, and that is easy. Then you have patient who is symptomatic, then you would treat. So these are the four paradigms of treatment that our clinician may be involved with. So we need to be very clear whether we are prophylaxing or whether we are doing preemptive, empirical, or targeted therapy. So I think in ICU we would dissuade this prophylactic use or even preemptive. I think in these two situations, I think we may be reasonable to consider giving antifungal therapy. Okay. So our approach to antifungal therapy, we'll just talk about the broad guidelines. The choice of initial agent is first question one needs to ask is whether this patient has had an azole exposure. Because if he's had an azole exposure, then what should run in your mind is that this patient is at a higher risk of developing non-albicans. And you have to look at prevalence and susceptibility data and severity of illness. Someone who has metastatic abscesses like this, then you cannot take a risk. Then you may have to start on a higher antifungal like echinocandins and then maybe de-escalate once the speciation is done. And you have to look at the comorbids. I think these are the four elements that one should sort of deliberate upon before embarking on the choice of antifungal agents and tolerance. So I think this is the rough sort of a guideline. Someone who has no neutropenia, who is hemodynamically stable, and who has not had azole prophylaxis, the choice of therapy may be fluconazole. So he has no neutropenia, he is hemodynamically stable, and who is not exposed to azole, then your understanding is he will have, even if he has candidemia, it will be a sensitive candida, and fluconazole may be the drug of choice. Someone who has no neutropenia but who is severely ill, and where you consider there is elderly patient 65 or who's had a solid organ transplant, where you suspect that he may be at increased risk of developing Candida glabrata or cruzi, which we know are resistant to fluconazole, then the choice of antifungal may be echinocandins. So if you have a patient who is neutropenic and who is at increased risk of fluconazole resistance because of previous exposure, then I think echinocandins and amphotericin B may be the reasonable drug of choice. In someone who is neutropenic but he is hemodynamically stable and who's not had an azole prophylaxis, still you could consider fluconazole as a first choice. So the crux of the issue is if it is hemodynamically stable, no neutropenia, then there's no reason to consider starting advanced antifungal like echinocandins. You can still start off fluconazole. But if it's neutropenic and hemodynamically unstable, then you may have to consider starting echinocandins. Or even if it is neutropenic, if it is hemodynamically stable, no azole, I think fluconazole can still be considered. Once candidemia treatment is started, I think the duration of therapy is much longer. So the suggested duration is around 2 weeks, and the guidelines do suggest daily blood culture. In Indian circumstances, this may be difficult. At least we may have to consider every 2 to 3 days blood culture to see clearance of candidemia, and we have to watch for resolution of symptoms and neutropenia. And once the speciation is got, once you know the species and sensitivity, like any other antibiotic therapy, we need to de-escalate to fluconazole if it is sensitive. If it is Candida cruzi or glabrata, we know they are resistant to fluconazole, but from echinocandins you can de-escalate to voriconazole. So now coming to the last slide is candidemia. So now we have discussed so much about candidemia. Is it something in intensive care we should worry about? Is it a marker of poor outcome? Yes, because 25% of the patients with candidemia can die. So the mortality is very high. And as I said, overall mortality rate is 30 to 80% depending on your index of suspicion and initiation of treatment. If you are not treated, mortality can be up to 80%. Even with treatment, I think mortality can be high in candidemia. It can be about 30 to 40%. And patients who have malignancies on the background or who is hemodynamically unstable, mortalities can be somewhere up to 80%. So it is a reason to be worried in ICU. If you are suspective candidemia, the first thing that should run in mind is mortality can be up to 70% if you not treat appropriately. And attributable mortality of candidemia is said to be around 38%. So the take home message for all the listeners is candidemia is the commonest fungal infections in ICU. In India, I have to re-emphasize again and again, non-albicans tropicalis is commonest in India. Candida auris is emerging to be problematic, and this is inherently resistant to azoles and even to some echinocandins. So posaconazole is claimed to be the drug of choice. We need more data to see the occurrence rate of this auris in India. And it's very important to identify risk factors for all the trainees. You can remember this picture. So CVC constitutes the highest risk for candidemia, followed by stress ulcer prophylaxis, especially proton pump inhibitors or pantoprazolization in ICU increases the risk of candidemia. So that's why we have moved away from routine stress ulcer prophylaxis. And longer stay in ICUs increases their risk, or inappropriate antibiotic usage, and someone who's undergone laparotomy. All these constitutes high odds of them developing candidemia. And with regards to the choice of treatment, if there is no exposure to azoles, fluconazole remains mainstay of treatment. But when there is neutropenia with exposure to azoles, echinocandins remain the drug of choice. And please remember, candidemia is a life-threatening condition and it does lead to increase in mortality. So I'll end my talk with this. We don't see things as they are, we see them as we are. So please keep candidemia or fungal infections in back of your mind, because unless we have an index of suspicion, we may fail to identify the patients with fungal infections. So please visit my website www.drpradeeprangappa.com so you can rehear to these lectures to gain more clarity and insight. Thank you very much.